Hi everyone. In this chapter, we will talk about disorders found in children and adolescents. These disorders develop in childhood and adolescence meet criteria according to the DSM-5 TR when there is significant impairment in their social, academic, and occupational lives. Children are assessed through a combination of interviews and observation. Watching children at play provides important clues to their functioning, as play is a safe area for children to act out their thoughts and emotions. So asking them to tell a story, draw a picture, or engage in specific games can be useful, especially when the child is having difficulty expressing themselves verbally. Although they may be the best source for understanding their inner feelings and emotions if they're able to articulate that, the caregivers, whether parents or legal guardians, can often best describe the child's behavior, how they've been performing in school, and their conduct at school and at home. Caregivers are also helpful in interpreting the child's words and responses, but a separate interview is advisable when the child might be scared or reluctant to share information, especially in cases of suspected abuse by the parents or guardians. For adolescents, they may be especially concerned with confidentiality and may fear that you will repeat what they say to you to their parents. And sometimes this could be difficult to navigate as parents give consent for their treatment and therefore have a right to know how their child is doing. So clinically and ethically, the nurse should consider or understand that certain zones of privacy exist even for adolescents. And when you're in these situations, it's appropriate to try to use your best judgment or seek out either your clinical instructor or a colleague if you're not sure what to do. The adolescent and the adolescent's family should be given an overview of how information sharing will work across them and the treatment team. What information will be shared, with whom, and when. Adolescents should receive an explanation of the role of the treatment team in providing care and the need to share certain information. So threats of suicide, homicide, abuse, or behaviors that put the patient or others at risk are shared with other professionals as well as with the parents. So a combination of factors affect the development of mental and emotional problems in this population. Many are hereditary, some are a result of gene or chromosomal mutations, imbalances in the neurotransmitters such as serotonin in autism spectrum disorder or dopamine in attention deficit hyperactivity disorder. There could be physical changes in their brain structure and activities, such as the size of their amygdala, as in autism spectrum disorder, the fluid volume or brain volume, such as in autism spectrum disorder and attention deficit hyperactivity disorder, the basal ganglia, such as in Tourette's disorder, limbic structures and low levels of cerebrospinal fluid, such as in conduct disorder, which can increase their risk of aggression and violence. Infections, substance use, or toxin exposures during the pre, peri, or postnatal periods, such as in the cases of intellectual disability disorder, autism spectrum disorder, and attention deficit hyperactivity disorder. There are also certain temperaments in a child that can increase their risk, such as being extremely shy, irritable, or having a very low frustration tolerance, especially with influences from the immediate caretakers and the environment. Their psychological resilience, how they bounce back and handle challenging situations, can influence how they respond and deal with the demands and expectations of their environment. So, for example, if there's a mismatch between parent and child temperament, and the parent is unable to respond positively to the child or nurture their development, then there could be a risk of, let's say, insecure attachment or developmental problems, such as in the disruptive behavior disorders. Environmental factors such as trauma, parenting or caregiving styles, the family dynamics, and exposure to high lead levels, such as in the case of ADHD, can affect their development. For example, neglect or constant rejection from the parents or primary caregivers, severe abuse, or punitive disciplines can increase the risk of developing conduct disorder. Neurodevelopmental disorders. These include intellectual disability disorder, autism spectrum disorder, attention deficit hyperactivity disorder, and Tourette's disorder. These are associated primarily with the dysfunctions of the neurological system and the brain. Onset is usually during the early stages of child development and affects the person's personal, social, and academic or vocational life. Intellectual disability disorder, or IDD, is characterized by deficits in cognitive, social, and their daily functioning. There are deficits in their ability to adapt to the demands of daily life and what we expect from their age and cultural group. So the more severe their IDD, the more support they'll need to adapt to the demands of daily life, whether that's one-on-one, constant supervision, and care. The degree of severity will also depend on 4 areas to which you'll also want to assess. So intellectual or conceptual functioning. This refers to their mental skills or cognitive skills that can affect their school performance and, as an adult, their work. You may see limitations in reasoning, problem solving, planning, judgment, and abstract thinking. But don't be mistaken, it's not a problem with intelligence or motivation, but the way that they receive and process information is different. They might have trouble learning new information and skills and executing them, so it's a matter of finding what supports they need or how something can be modified to fit them. Additional things to ask yourself or to assess is, what is their level of understanding of the information presented? What is their reading or writing level? Would they benefit from academic or vocational training? Social functioning refers to their interpersonal skills and ability to maintain meaningful relationships. So you might see impaired communication and language, difficulty in interpreting and acting on social cues, and difficulty regulating emotions. So assess, how do they communicate? Some may communicate well, while others may have little to no speech development or socialization skills. If it's the latter, are there other forms of communication that they use? What is their tolerance or frustration level during social activities? What behaviors do they exhibit during these moments? And how does this impact their relationship with others? Practical or daily functioning refers to their capacity to perform activities of daily living, or ADLs. Ability to perform self-care activities, we want to know to what degree can they do it independently, or do they need assistance and supervision? Their psychomotor capabilities, do they display fine to gross motor movements that require a certain level of supervision? For example, can they hold a spoon and manipulate it by scooping the food and putting it up to their mouth? Autism spectrum disorder, or ASD, is a neurobiological and developmental disability that typically appears during the first 3 years of life. It affects the normal development of social interaction and communication skills. It's rated from mild to moderate to severe based on their lack of responsiveness to or interest in others, a lack of empathy or sharing with peers, and little or no cooperative or imaginative play. So therefore, impaired socialization could be present. They may exhibit impaired communication as evidenced by a delay or absence of language, and the stereotyped or repetitive use of language. There's also stereotyped and repetitive motor movements, which include behaviors such as head banging, face slapping, and hand biting. And some have a very high tolerance to pain, maybe due to delayed or numbed sensation, which can result in serious self-injury, so risk of injury can become a priority. For ASD, the second generation antipsychotics Risperdal or Risperidone and aripiprazole or Abilify are currently approved by the FDA. They do not treat the core of ASD, but do target behaviors such as aggression, self-injurious behaviors, temper tantrums, and fluctuating moods. Uncommon but serious side effects of risperidone include neuroleptic malignant syndrome, tardive dyskinesia, and metabolic disorders. Commonly reported side effects and adverse reactions of aripiprazole include sedation, fatigue, weight gain, vomiting, somnolence, and tremors. SSRIs can also be used, but off-label, to improve mood and reduce anxiety, which may be helpful in social interactions or tolerating new situations. Okay, so what can we do to plan and intervene for those with IDD or ASD? When considering the safety of the individual and others, it's important to monitor any behavioral cues that signal increasing anxiety and the potential for injury. If they are non-speaking, consider if they are trying to communicate an unmet need. Potential outbursts can be diffused through early recognition, verbal interventions, or removing the person from the stimuli. Consider if and how the environment could also be contributing to the behaviors or the escalating anxieties and frustration. Some are sensitive to loud noises. If they are non-speaking, they will communicate with behaviors. And consider if their nonverbal communication poses harm to themselves or others, such as if they're really frustrated, they might end up hitting themselves. Think as well if it's a situation that you have to remove them from. Maybe offer them a quieter space. Limit or have consistent caregivers to help facilitate a trusting relationship. Identify aspects of self-care that may be within the person's capabilities. For example, working on one aspect of self-care at a time, and once they master that to the best of their ability, you can move on to the next. Encourage independence in activities, but intervene when the patient is unable to perform. This would be an opportune time for additional assessments, such as their tolerance to performing a task. Give them decision-making opportunities if they're able to. For example, instead of picking their outfit, you can give them choices. Provide simple, concrete explanations. Maybe about 3 to 5 words per sentence, with intentional pauses to give the person time to process information. It could be frustrating for some if the information is overwhelming or if they're not able to follow. Limit self-stimulating and ritualistic behaviors by providing alternative activities or providing them comfort when they're stressed. Try redirecting the patient's attention to maybe a favorite or new activity. Anticipate and fulfill the individual's needs until a pattern of maybe expectation or how they're communicating are established. Some thrive on structure, and any small change can cause extreme distress or behaviors. So will it help the person know in advance what they're about to do and what will follow it? Or if you see that they might be feeling cold on the unit, for example, offer a blanket and socks for additional warmth instead of waiting for them to ask. Plan for positive reinforcement, especially for desirable behaviors. So this is based on behavioral theory, and the hope is to see in time an increase in how often the desirable behavior occurs over the maladaptive ones. Offer positive feedback. This could be reframing your verbiage to be more positive. So, for example, instead of telling them what not to do, tell them what you want them to do. So like instead of saying, if they're brushing their teeth and you're saying, you're doing it wrong, instead give them the direction on how you want it to do, how you want them to do it, such as brush up and down. And assist in improving social functioning and verbal communication. Understand the person's way of communicating. Learn special words that they might attribute to certain things that make it unique. Identify nonverbal gestures or subtle cues that indicate that the person is either maybe paying attention or is attempting to communicate. This is especially helpful for those who are non-speaking but can still communicate through nonverbal behaviors. They could need you nearby during initial interactions with their peers, for example, and if they allow, you can also help explain some of their own language, their own gestures, and others' unique communication attempts to their peers or other staff members. Attention Deficit Hyperactivity Disorder, or ADHD, is characterized by inattention and/or hyperactivity and impulsivity that interferes with development and functioning in their life. They may find it very difficult to focus or complete tasks, especially if it's time sensitive. So inattention can look like missing details, making careless mistakes on assignments, difficulty focusing on situations or tasks that require attention, and forgetful in daily activities. So, for example, try doing a puzzle with them and see how long they can stay engaged. Are they able to sit through groups or interviews? Hyperactivity includes aimless or unintentional motor behaviors, such as not being able to remain seated in situations that require them to be, talking excessively, and having a difficult time waiting in lines. Impulsiveness is the sudden need to act without thinking of or considering consequences of that action. So these characteristics can contribute to feelings of low frustration, having temper outbursts, labile moods, having poor school performance, or even having difficulty in their family life and friendships and relationships. And they can also have feelings of low self-esteem. Additional assessment will include level of physical activity, especially in relation to their impulse control. They can display intrusive behaviors, such as interrupting others or invading others' personal space. Excessive levels of activity or psychomotor agitation can lead to risk for injury or property destruction. Assess their social skills, relationships, problem-solving skills, and school performance. How do they interact or socialize with others? Sometimes they have difficulty maintaining friendships because of poor social boundaries or lack of socially acceptable interpersonal skills. Do they display aggressive, intrusive, or regressive behaviors? And if so, do they find this makes it difficult to make or keep friends? Assess for mood disturbances, such as anxiety, irritability, and depression. Are these persistent in the person's life? Anxiety and depressive disorders are common comorbidities of ADHD. Ask about their eating and sleeping patterns and monitor these regularly, particularly if the child is being treated with stimulants. Stimulants have natural properties that can keep them up or decrease their appetite. So ADHD planning and implementation. We want to ensure that the client remains free of injury. So protecting them from harm and providing for their physical and emotional needs. Maybe removing objects that could injure themselves as a result of random hyperactive movements. Managing those disruptive behaviors through modeling, planned ignoring as long as safety is not a risk. Redirecting those behaviors or setting limits. Encourage appropriate interaction with others. This might start with us as their nurse, by providing one-on-one interactions, maybe utilizing role-playing to practice skills, or providing immediate feedback regarding what's acceptable versus unacceptable social behaviors. We may need to be available to help them problem solve any peer conflicts and role model social skills as a way to develop interpersonal skills. Increasing feelings of self-worth by demonstrating basic acceptance and respect regardless of what they say or do. Reinforce the patient's self-worth with your time and attention for positive behaviors especially. Fostering motivation to practice tasks. Provide low stimulating or distraction-free environment to practice these tasks. The steps or instructions might need to be simple to follow, and use positive reinforcement after each step. Help family understand the diagnosis, expected treatments, what are realistic plans or goals, and if needed, teach behavioral principles such as positive reinforcement for good behavior and logical consequences for negative behavior. So CNS stimulants such as dextroamphetamine, lisdexamphetamine, methylphenidate, dexmethylphenidate are mixtures that are the first line of treatment for ADHD. These medications are thought to increase dopamine and norepinephrine levels, which are the neurotransmitters that have everything to do with motivation, impulse control, attention, and concentration. Common side effects include insomnia, weight loss, tachycardia, and appetite suppression. You would want to make sure that they eat regularly throughout the day. It's most effective when it's taken on an empty stomach. To address insomnia, it should be taken in the morning. These are contraindicated in those with cardiac risks. There is also a potential for new onset psychosis and the potential for dependence. Children on these medications also have a higher risk of injury-related hospital admissions. Non-stimulant medications such as Wellbutrin, Strattera, guanfacine, and clonidine can also be an alternative for these individuals, especially if their anxiety is increased when taking the stimulants. Atomoxetine, a serotonin norepinephrine reuptake inhibitor, may take up to 6 weeks for full improvement. Common side effects of this medication include GI disturbances, urinary retention, dizziness, fatigue, and insomnia. Off-label uses of the antidepressant bupropion and the alpha-2 adrenergic agonist clonidine and guanfacine can also be prescribed to target ADHD symptoms. Clonidine and guanfacine are both commonly prescribed to target impulsivity. Tourette's disorder is a type of tic disorder that consists of multiple motor tics and at least one vocal tic for more than 1 year that interferes with daily life. Tics are these sudden, non-rhythmic, and rapid motor movements or vocalization. They're compulsive, involuntary, and challenging in nature to stop. Motor tics include eye blinking, neck jerking, skipping, tapping, retracing steps, and others. Examples of vocal tics include words or sounds such as squeaks, grunts, or barks. They may also include repeating certain words or phrases out of context, repeating one's own sounds or words, or repeating what others say. Onset may be as early as 2 years, but occurs most commonly around ages 6 or 7, and is more commonly seen in boys than in girls. Assessment will include their impulse control, their mood disturbances, any psychomotor agitation, and speech patterns. It's also good to see if they're able to control the urge to tic. Tics are usually triggered by some kind of stressor, so it's good to identify what those could be. Understand how they have dealt with this and how have the symptoms affected their life. it can be very challenging for them to cope with their emotions and develop friendships. They might experience bullying because of their tics and can contribute to feelings of rejection, avoidance, and social isolation. Half of those with Tourette's disorder are also diagnosed with ADHD. And if they are prescribed stimulants, they should be monitored as it can worsen their tics. So nursing interventions are going to focus on safety and behavioral interventions, which teaches them how to change their behavior over time and tic less. Tics are often done in response to a feeling or urge, and with behavioral interventions, they can learn to stop it at least for a short amount of time. So we want to plan for their physical safety. Sometimes their impulsive behaviors and psychomotor agitation, of which sometimes they can't control, can increase their risk of injury. Work with the patient to identify situations that increase the tics. Address their feelings of anxiety, as this can also worsen tics. Discuss what has been helpful and not helpful in reducing it. Consider their individual stressors and work on trying to create a less stressful environment. Strengthen the control of tics through coping mechanisms of handling stress. What are enjoyable activities that decrease their tics and calms them? What situations make it better or worse? Talk about the steps to maybe fight back against the urge and put off doing the tic. Make up and practice quote-unquote competing responses. For example, in place of your hand coming up, you push it down. Encourage self-assessment and having them record potential associations between their physical self and life situations, including any events or interpersonal interactions that could trigger those tics to make those connections. Find ways to promote feelings of self-worth through supportive therapy. So they may have low self-esteem as a result of feeling ashamed, self-conscious, and rejected by their peers. And that might limit them in going out in public for fear of displaying those tics. And of course, it's important to include the family or caretakers of the child to determine their understanding of the disorder, recognizing symptoms, discussing the coping strategies jointly, and developing interventions that support both parents and the child. This can enhance the parents' capacity and confidence in supporting their child. So the antipsychotics haloperidol or Haldol and aripiprazole or Abilify have been FDA approved for treating tics. Alpha-2 agonists such as guanfacine and clonidine are used to treat symptoms and reduce the severity and frequency of tics. Medications that can be used in conjunction with therapy is the most effective. Comprehensive behavioral intervention, or CBIT, also known as habit reversal, can help reduce tic severity by raising the patient's awareness of the building of a tic urge, and then using a competing or incompatible response against it. Another example of this would be if their tic is to turn their head to the left, a competing response would be for them to try to turn their head slightly to the right. Speech therapy can also help with any barriers to communication, including strengthening the muscles used in speech. And as a last resort, deep brain stimulation can be considered. 2 small incisions are made in the scalp, and with the help of MRI, a fine wire is threaded into the affected areas of the brain. These wires are connected to a small device implanted under the collarbone that delivers electrical impulses. The individual can turn the device on to control tics or shut it off when they go to sleep. Disruptive behavior disorders are characterized by aggressive behaviors and emotions in children and adolescents. They have problems relating to others in socially acceptable ways, which can affect their relationships and contribute to social isolation and impaired social interaction. They most likely have run-ins with the law and have problems with authority. Oppositional defiant disorder, or ODD, is characterized by angry or irritable mood and passive-aggressive behaviors, such as argumentativeness, defiance, and vindictiveness. These behaviors last most days for at least 6 months. They often blame others for their problems and make unreasonable demands on them. So assessment will include identifying issues that result in power struggles and triggers for outbursts, when they begin and how they are handled. They can be impulsive and lose their temper easily, and they don't respond well to authoritative figures and have trouble following rules. You want to also assess his or her behavior and its impact on others, whether at school, at home, or with their peers. They often experience negative interactions with others because of these behaviors, perpetuating the cycle. Explore their ability to develop empathy and remorse through debriefing or reflection of situations that involve others. Explore the degree to which the person can exercise control and take responsibility, solve problems, and plan to handle things more effectively in the future. Assess their barriers, their motivation to change, and the use of potential rewards to engage the patient. Conduct disorder, or CD, is characterized by unusually aggressive behaviors in which the rights of others are violated and societal norms or rules are disregarded for at least 6 months. Behaviors often lead to destruction of property or physical injury. These individuals usually try to initiate physical fights and engage in bullying. They might steal, use weapons to intimidate others or hurt others. They may even use threatening language to force someone to do something against their will. Additional assessments going to include the seriousness, types, and initiation of disruptive behaviors and how it has been managed. Assess their anxiety, aggression, and anger levels, motivation, and the ability to control impulses. Obtain a history of criminal activity and violence. A history of violence is a strong indicator of their likelihood to engage in it again. Assess their moral development, problem-solving skills, their belief systems, and spirituality for the ability to understand the impact of hurtful behavior on others, to be able to empathize with others, and the possibility to feel remorse. Assess their ability to form a therapeutic relationship and engage in honest and committed work into changing their behaviors. So this might look like them signing a behavioral contract and carrying it out, drug testing when it's warranted, or even living according to the rules at home. Assess for substance use, both current and history, as substance use is common with these individuals. So the long-term goals for interventions are to focus on correcting those deeply ingrained patterns, such as them blaming other people or not taking accountability for their own actions. Using positive reinforcement or giving the client some positive attention when the behavior is not problematic will be helpful. But most likely they'll receive majority of attention from other people when they are engaging in problematic behavior. So this is the pattern that we are trying to change. In addition to these long-term goals, we want to help them develop mature and adaptive coping mechanisms and also pro-social goals so that they can be a part of society and be able to maintain and keep friendships and relationships. So general interventions, they're going to include promoting the safety for themselves and others, frequently observing for signs of increased agitation or self-harm behaviors, and if you're on the inpatient unit, communicating this with the staff. Offer the PRNs if needed, and if it's safe to do so, in conjunction with non-pharmacological activities. Consider if the staff interactions are also contributing to an unsafe environment. For example, if they're engaging in power struggles, which can trigger this outburst or response. Establish rapport with the patient. Convey acceptance of the person separate from their behaviors. They frequently experience rejection, especially from adults. Giving them the opportunity to express their feelings can be a good start in establishing that rapport, as it probably is uncommon for them to do so. Set limits and expectations about any manipulative or disruptive behaviors. So setting limits might involve giving direction or stating an expectation. Within these diagnoses, the delivery is also important. So if you're acting in an authoritative or confrontational manner, this can increase their hostility. Instead, address it in a neutral, firm tone and ensuring that your body language is non-threatening. Provide structure and boundaries. Manipulative behaviors can be addressed with designating one staff member to be their primary contact, for example. Or, if needed, regular or frequent communication between the interdisciplinary team might be necessary to discuss other problematic behaviors and evaluate the interventions. Consistently follow through with consequences of rule breaking, and discuss unacceptable behaviors and the consequence that would follow it in a non-threatening and matter-of-fact way. It's important to follow through. Consistency or disengaging in a power struggle can also discourage manipulative behavior. Provide activities or opportunities to achieve goals that promote a sense of purpose. This could help them be productive and model positive interactions that can decrease the space for those disruptive behaviors to occur. Institute a daily schedule in conjunction with a person to increase chances of compliance. Provide education for the client and the family or caregivers about the disorder and how to manage any challenging behaviors. Provide resources if the family might need additional help in supporting their adolescent long-term. Separation anxiety is a normal part of infant development starting around 8 months of age and peaks about 18 months. As a disorder, separation anxiety is characterized by excessive anxiety, worry, or fear that is unusual for their developmental level. Usually these feelings and beliefs are about separation from and/or the possible harm to someone they're strongly attached to, usually a parent. These symptoms should persist for at least 4 weeks, and onset can be as early as preschool age. In the context of separation and attachment, you might see behaviors such as tantrums, crying, screaming, somatic complaints, and clinginess. They may be reluctant or they might refuse to go anywhere without their person, even school. They may even have sleep disturbances such as nightmares or fear of sleeping away from them. Their nightmares may have themes of separation. Many of these symptoms can look similar to other mental health disorders such as specific phobias. So having a comprehensive assessment will assist in the interdisciplinary team in making an accurate diagnosis. As adults, these clients can develop generalized anxiety disorder. Early intervention can reduce further disability related to the anxiety. Intervene at early signs of anxiety or anticipate anxiety-provoking situations and prepare to address them. For example, if we know the client might throw a tantrum when their parents end the visit, discuss with the interdisciplinary team, client, and family the best way to approach this so that everyone's on the same page. We want the client to have family visits, and we also want the client to understand that these visits are time limited and hospital policy is, let's say, overnight guests are not allowed. Although this may not completely diminish the tantrum, the client will at least know what to expect and the staff will be ready to intervene. In the event of an anxiety episode, especially related to separation, we want to help the client maintain their anxiety at a manageable level. It would be helpful to know what that can look like for the client based on their input and the families. But if you don't have that information, staying with them during an episode, speaking slowly and calmly, using short and simple sentences can help the client feel secure. Consider as well if the environment is contributing and modify accordingly. It's good to review the different levels of anxiety and how it affects the person's perception, cognition, and behaviors, which can be seen in Chapter 1. So like a mild level of anxiety can be more productive at, let's say, practicing coping skills or self-awareness, than versus if you do it as severe level anxiety where their ability to problem solve feels impossible. Identifying goals individualized to the person might be helpful in preventing overwhelming emotions. It can be discouraging to the client to set a goal that is not realistic and might even impact their self-esteem. So as young people use maladaptive behaviors over time, they become more vulnerable to developing other psychiatric disorders. Talking about their experience and helping them identify emotions is essential for their understanding, especially at a young age. Teach and offer opportunities to practice healthy ways to cope with anxiety, such as deep breathing, mindfulness, taking a warm bath, singing, distractions, or listening to music. Both the client and the family members may need education on the disorder and may have to change their behavior based on their goals. Teaching the family, for example, how to set limits without being harsh can help the individual feel in control. Ideally, treatment of childhood and adolescent disorders uses a multimodal approach of coordinated care. You might be working with the child's school or mental health professionals that also help provide behavior modification. Medications previously discussed are most effective when combined with any of the following therapies. Behavior therapy is based on modifying behaviors through positive or negative reinforcements. A lot of our interventions are based off of behavior therapy. And it can be effective with any of these disorders, but especially with disruptive behavior disorders. Families and caretakers, they can be taught how to implement this at home. For example, rewarding positive behaviors by maybe using a point system to reduce the maladaptive behaviors. Some hospitals utilize this concept to earn privileges through demonstration of treatment-focused behaviors, such as attending therapeutic groups, taking medications, and not causing any disruptions on the unit. Family therapy. Families are involved in therapy whenever possible and is often a key component of treatment for child and adolescent disorders. They are given support in parenting skills to help them provide a nurturing environment and to set consistent limits. Parents can also learn how to use those behavioral techniques, how to monitor medication effectiveness, and how to make the home environment a place that promotes achievement of milestones or developmental tasks. In extreme cases when the parents are abusive or they use substances or are extremely dysfunctional, the child or adolescent may require out-of-home placement, such as in group homes. Group therapy can be helpful for the child or adolescent to learn appropriate social behaviors, practice skills in a safe environment, and learn from the experiences of their peers. It could come in many forms, such as music therapy, arts and crafts, or group play therapy, which is a treatment of choice for kids that are 3 to 9 years old.